Good afternoon. My name is Sharon Lewin. I'm Director of the Doherty Institute, a joint venture of the University of Melbourne and Royal Melbourne Hospital. And it's a really great pleasure to chair the first of a seminar series called the Sino-Australia COVID-19 Seminar Series. I'd like to first of all start, as we do in Australia, with an acknowledgement of the land upon which we're meeting, alas, virtually, but nevertheless a land that belongs to the Indigenous people of Australia, and pay my respects to their elders, past, present and emerging, and welcome any Indigenous people here today. It's a really great pleasure for me to launch this seminar series. It's part of a broader program that we recently developed between the Doherty Institute and 3 universities in China, Hong Kong University, Fudan University and Tsinghua University. The program is generously sponsored by the Australian Government, Department of Foreign Affairs and Trade, acting through the National Foundation for Australia-China Relations. And it's designed to support collaborations and partnerships in scientific research or health-related projects, specifically on COVID-19 between Australia and China. And back in January, when we first heard about the coronavirus, this new coronavirus from Wuhan, Australian scientists, and particularly at the Doherty Institute, rapidly became very, very involved in testing, advising the government on policy, developing programs around treatment and vaccines. Many of us have worked for many years with various colleagues across China, and I'll talk a little bit about that in a moment. But collaborating back in January and February, when China was coping with this brand new infection, was really quite difficult for understandable reasons. But here we now are, 9 months into the pandemic. So much has been learnt about SARS-CoV-2 and COVID-19, and so much fantastic work, of course, has come out of China. And we think this is a great opportunity to strengthen our collaborations that have been going for many years prior to this event and focus on COVID-19. So the purpose of the program, or how we intend to run the program, is to have a seminar series that will include a speaker from the Doherty Institute and a speaker from one of our partner institutions. And we hope to cover a range of areas: public health, fundamental virology, immunology, clinical trials, and maybe government policy as well. And at the same time, we're able to seed fund some collaborative research programs. Each of those would be 50,000 Australian dollars, which bring together both Chinese and Australian investigators. I'd like to first of all, before introducing our speakers, acknowledge our partners in China. And they include the University of Hong Kong, Professor Keiji Fukuda, who's the Director and Clinical Professor and Head of the School of Public Health at the Li Ka-shing Faculty of Medicine, Professor K.Y. Yuen, who's the Head of Department of Microbiology at the University of Hong Kong, and Professor Zhuwei Chen, a Senior Scientist in the Department of Microbiology and the University of Hong Kong. There are partners from Hong Kong. We're working with 2 departments within Hong Kong University, Microbiology and Public Health. Also like to acknowledge Professor Linqi Zhang. Linqi is the Professor and Director of the Comprehensive AIDS Research Centre at the School of Medicine, and also Professor and Vice Dean of the Vanke School of Public Health at Tsinghua University, Beijing. Linqi has an active program in looking at antibodies to COVID-19. And our University of Melbourne, has worked extensively with Tsinghua University in training a joint master's program, and we look forward to many other collaborations with Tsinghua University beyond infectious diseases. And finally, Professor Zheng Hong Yuan, who's the Vice President of Fudan University, Professor and Director of Department of Medical Microbiology and Parasitology, and Director of the Key Laboratory of Medical Molecular Virology at the Shanghai Medical College of Fudan University. And Professor Yuan has been working with the Doherty Institute, an initiative led by Professor Catherine Kociewska for many years now on infectious diseases. There's been a range of visits to Melbourne and to Shanghai over the last 5 years, and we're delighted to work again with Professor Yuan on this special initiative for COVID. I also want to thank a few other people that have been instrumental to getting the program going, and that's Mason Littlejohn, who's been providing all the support for arranging the seminars and grant program, and Andrea Fisher, the Executive Officer of the Doherty Institute. A few housekeeping rules for today, our first seminar. We're going to hear from our two speakers who will each speak for 15 minutes. So that will take us about 30 minutes. And then we'll open up for a Q&A with the audience. And you can type in your questions in the Q&A box, and Mason will pass them on to me to make sure I can ask them. We're using quite a professional platform for our seminar program, so unfortunately we can't ask you to ask your own questions, but I'll hopefully be able to get through all of those in the 25 minutes we have for Q&A. So I'm really excited about this program. It's funded to last for the next 12 months, but I think we could make this a huge success and hopefully extend it into other infectious diseases beyond COVID-19. So it's my very great pleasure to introduce our first speaker. Our first speaker is Professor Jodie McVernon. Jodie is the head of epidemiology here at the Doherty Institute. Jodie has been playing a leading role in the COVID-19 response through her work in mathematical modelling, and it's been a fantastic example of how researchers can work with government to inform government policy. And Jodie's been at the table with our government policymakers since day one. She's been attending a brutal schedule of meetings, which I think have been pretty much every day until recently, and juggling a huge amount of her own research as well at the same time. So an extraordinary effort from Jodie in response to COVID-19 all year. So I could think of no one better to tell than Jodie to tell you about COVID-19 epidemiology in Australia. So thank you, and over to you, Jodie.
Thank you for the opportunity to present today. Thanks, Sharon, for that introduction. And over the next 15 minutes or so, we'll just talk briefly through the journey of COVID-19 in Australia over the past 9 months, just picking out some of the key features of the epidemiology that we've experienced here. Australia is a very large island, and we often refer to ourselves as people living in 7 cities on the coast. This nighttime photograph sort of shows you that we live very much around the edges as a population in general, but we do have large regional and remote populations, particularly in the north, and need to attend to their needs. But part of the consequence of this broad geography is that many parts of the country may experience disparate epidemics. We're in different phases of response at different times, and our populations have different needs. To highlight that, here, this slide is a daily update from the National COVID reporting platform. This is actually 2 days old because I had to prepare my slides yesterday. But as of 2 days ago, we had 27,000 cases of COVID cumulatively in Australia since the beginning of the epidemic, with nearly 900 deaths. But to make the point of our geography here, on the right-hand side where you see the map of Australia with the lines showing state and territory boundaries, 20,000 of those infections have been in Victoria, the state where Sharon and I live, right down here in the southeast corner. And Victoria and New South Wales are our most populous and connected states, but really Victoria has borne the majority of cases of COVID-19 to date. This central figure shows that we've had 2 waves, and we'll come back to this. At the moment, we're well under control with only 6 cases in intensive care and 46 in hospital. And we have had a very high testing rate throughout the epidemic. So we're fairly confident that we have good knowledge of our local epidemiology. As in many other countries, our peak transmitting populations have been young working age adults. Our peak deaths and burden of disease have occurred in the elderly, and we'll talk more about that. So here's just a slightly more detailed figure showing the 2 waves of infection that Australia has experienced so far. And I guess the key characteristics comparing the first to the second is the first is made up of many colours and the second is all one, and that second is Victoria. So our first wave, as in Hong Kong and many other places, was really a wave of imported infections. It reflected the epidemiology of travellers arriving in Australia and the status of the epidemics in their countries. And having had very early border restrictions and travel restrictions, we did start to see those waves of travellers increasing in early March, at which point voluntary quarantine arrangements were introduced. That was upgraded to hotel quarantine on the 28th of March, the point at which that first wave really peaked. And with the imposition of additional social measures, including a first lockdown and imposition of a 2-person public gathering rule, that first wave came under control very effectively. But as you can see, something went wrong. If we look at the isolates that arrived in Australia during that first wave, this figure is a little fuzzy to me, so I hope it's a little clearer to you. But really the key message of it, if we look at the genomic clusters on the left, is that many clusters were imported into Australia from all over the world. As we say, this was a wave of imported infection. And looking on the right to see what happened next, we can see a few dense, tightly connected clusters of secondary infection spread, but most of these were dead-end events. Most of these imported infections did not spread further, and really this reflected the quarantine arrangements in place at the time, which were largely effective. And what we found was that all of these early imported isolates and lineages effectively were eliminated by the end of that first wave. So how did the infection get back in? Well, obviously Australia has had very stringent travel and border restrictions, but we have had international arrivals and regrettably a breakdown in protocol in infection control in the hotel quarantine system did lead to 2 episodes of infection being seeded from separate events into the community. And genomics have confirmed that all of the cases in the current outbreak really have arisen from that beginning point. There's obviously been a marked inquiry into hotel quarantine, and that inquiry has reviewed hotel quarantine arrangements around the country. I think one of our challenges, as with many other countries, is understanding what the stringency of quarantine will need to be around arrivals over the longer term, how we will assess the risks of infection in arriving travellers based on their country of origin, and what other testing and screening and supportive protocols might be put in place, because obviously hotel quarantine is a very arduous and costly system and necessarily limits the number of arrivals into Australia. But clearly here we had a problem. One of the key challenges about the seeding of this second wave, and this mirrors what's been seen in other parts of the world, was that it was seeded into communities of lower socioeconomic advantage than those who experienced the first wave, who tended to be returning international travellers. This meant that many of the communities that were affected may be culturally and linguistically diverse communities who, for language or other reasons, were less engaged with the public health messages or had real or perceived barriers to accessing medical care. So we saw many late diagnosed cases, by which time transmission to household members and potentially into workplaces had occurred. And also people just living in less advantaged conditions where there was more crowding, so household spread of infection was much more likely. And we had some very highly publicised outbreaks in public housing towers in the centre of Melbourne, one of which is shown here. A number of these towers were locked down to prevent the spread of COVID in settings where there were many shared facilities and laundries and lifts and stairwells, where there was a lot of close contact between people living in very crowded settings. One of those lockdowns did continue for a full 2 weeks, and like everything else about COVID, this was not an intervention that had ever been envisaged. So there were many lessons learned about community engagement, about the logistics, about the support services, about the mental health services needed to assist the residents through this period. And many residents of these towers were people who may have come from countries where they had experienced trauma, and this was a very triggering event. There were also a number of isolated elderly people living in these towers who were at high risk of severe disease outcomes. So this was a very complex situation to manage, and really one of the more challenging lessons learned from the pandemic in Victoria. The other population who were very challenging to manage, and again, this mirrors the experience of countries overseas, was our residential aged care system. So rather like the UK and Canada, who've had particular problems with outbreaks in this setting, as community transmission rose, we saw many episodes of importation into aged care environments. Again, this reflects the amplification of disadvantage, that many of the workers who work in this setting are relatively poorly paid. Many of them work multiple jobs within and beyond the aged care sector. And so opportunities for transmission and acquisition of infection in essential workplaces where people needed to work were then seeding infection into groups of people at very high risk of severe disease outcomes. And there were a range of financial and other incentives and working with aged care providers to try to ensure that workers limited their movement between different settings, and a raft of measures put in place within aged care to strengthen infection prevention and control measures and to develop really coordinated responses to situations where it was possible to have very large outbreaks and furloughing of large numbers of staff. And so the need to ensure continuity of care was a real challenge. So this was a combined Commonwealth and state government responsibility, given both have roles in aged care. So this was a very complex coordination piece, and we're still really unpicking the lessons learned in this sector that can support similar responses in other parts of Australia that haven't yet experienced this challenge. But also this is a setting where case numbers are still grumbling at low levels as we near the tail of our second wave. So just looking a little bit more at what the numbers in Victoria look like now. Again, this is from a daily updated dashboard as of Monday at this point. And today, actually, we have only 6 cases in the last 24 hours. So as anticipated, very stringent lockdowns that were imposed in Victoria have really brought case numbers down. But they have had marked social and economic impacts, and we're currently in a reckoning phase to work out how measures will be eased and when. We've had a lot of testing. We have still, though, grumbling transmission, as I said, in aged care and in some complex social settings. And so our numbers are sort of hovering tantalisingly around 10, just above or just below on a daily basis. And at the moment, we're waiting over the next 14 days to see if restrictions will be eased. And that has been a source of great interest to Victorians who are addicted to the daily tweet from the Health Department. The cases in Victoria, though, have largely been urban. So if we look at the case numbers by location on the bottom left, it's actually quite hard to see this slide now because case numbers are low. So we have some areas shaded in light grey. We have Port Phillip Bay in the middle, and surrounding that are these inner areas, and then a few of the regional areas just adjoining metropolitan Melbourne are still affected. We have people who are essential workers who move in and out of the metropolitan area, but we essentially now have a state that's in two response phases. So not even just different states and territories are in different stages, but regional Victoria, because of its very low case numbers, is actually now on a lower level of restrictions than metropolitan Melbourne, and a ring of steel divides us with police patrolling the roads between. So we are down to low numbers. We have moved from a first wave where most of our cases were acquired overseas to one where they're predominantly acquired in Australia by contact with a case. The other case numbers that we're watching very carefully here are these ones in grey, which are the unknown source cases or mystery cases, which are reflective of community transmission that's leading to chains of infection that we can't link to identified clusters and outbreaks. So as overall numbers come down, those numbers are coming down, and we are waiting to see whether we will achieve our targets. Just to show how the restrictions have worked, this one of the key epi features, I think, of this whole epidemic has been a really renewed attention on mobility data as an indicator of how movement restrictions have been working and how they are being complied with. Here is one such indicator. This is Facebook's staying put reported data. And this is covering the whole period from March to October. The blue or purpley lines are metropolitan local government areas in Victoria, and the orange and yellow lines are regional areas. And we can see that in the first wave, when measures were imposed in this shaded pink area here, a far higher proportion of people were staying put and staying home. And as measures are eased, that proportion falls. There were some early restrictions imposed in Victoria, which were then substantially strengthened with stage 4 when we see staying put rising. But you can see that regional Victoria is on a different policy setting, and so far fewer people are doing so there. So it's a very good indicator of activity. We're watching these numbers quite closely, and in Victoria, as we come into spring, fewer people are staying put, but our survey data tells us that when they're not staying put, they're obeying social close contact precautions. So we think that that's not particularly of concern. And some modelling performed by another group at the University of Melbourne was used by government to set targets. At the moment, we're waiting for a rolling 14-day average of 5 cases to be able to move down to the next stage of restrictions, which is a very small number. So there is considerable attention being paid to that 14-day average. One of our key success stories in Australia has been to protect a population who are recognised to be at high risk of severe disease outcomes. Our First Nations population, like other First Nations groups, has experienced long-standing disadvantage as a result of colonialisation. And there has been fabulous engagement throughout our response with First Nations community leaders and strong national leadership to ensure that a community-driven response has been put in place. And to date, we have a very, very small population of our cases in this community, which has been a great success so far that we hope we can maintain. So where to next? As we transition out of stage 4 lockdown, what measures will be eased and ongoing in Victoria is our question. We're obviously consolidating lessons learned about aged care and other settings. Our testing strategies are being refreshed and renewed, looking at alternative testing modalities to help provide confidence in our current elimination status, which still remains around most of Australia, and to enable early detection. And that clearly will help us to be more mobile within Australia, but also internationally. We, like others, are entering early agreements with vaccine manufacturers, scaling up capacity and working out objectives and strategies for allocation. And part of that is a commitment to ensuring early access for Pacific neighbours and Southeast Asian regional partners. But if no vaccine is imminent, I think Australia will be facing the question over time of whether our current strategy is sustainable and thinking about what our COVID normal looks like into the future. Thank you very much for your time.
Thanks, Jodie. That was a fantastic introduction, especially for our Chinese colleagues, about the situation in Australia. Now, it's a great pleasure for me to introduce our second speaker, who was actually with us in the very early days in Melbourne back in February, when we all thought this was an exotic, kind of outbreak in China and Hong Kong, and we were still moving around the world. Quite interesting, Ben, that was probably your last venture out of Hong Kong, maybe. So I had the opportunity of meeting Ben back in February here in Melbourne. Ben's a co-director of the WHO Collaborating Centre in Infectious Diseases, Epidemiology and Control, the School of Public Health in the University of Hong Kong. Many of us have been watching and reading some of his fabulous publications over the last few months, and just delighted that he's agreed to be a speaker at our inaugural seminar. So over to you, Ben.
Thanks very much. Yeah, I'm happy to share a little bit about what's been happening in Hong Kong. Actually, there's a lot of similarities with what Jodie described has been happening in Australia. So in Hong Kong, we have a population of 7.5 million people, less than Australia, of course. And we've had so far just over 5,000 cases. We had a first wave in March and April, shown on the left of this figure. The blue bars are cases who acquired their infection overseas. So we call those imported infections. And most of our first wave were actually imported infections, and some cases linked to those. And then we got that under control, had a bit of peace and quiet in April and then May and June. And then we had a big second wave with about 5,000 cases that, again, we got under control, but with a lot of local transmission, really not very much importation of infections by that point. And I think that mirrors what's happened in Australia as well. Even the timing is very similar. If any of you have followed the news in Hong Kong about first wave, second wave, third wave, fourth wave, actually on the left-hand side of this figure is what's referred to locally in Hong Kong as our first wave, based on a small number of infections imported from mainland China and a very small limited amount of spread of infection inside Hong Kong. So from mid-January until the end of February, locally in Hong Kong is called our first wave, and then the epidemic curve shown in blue in March is called our second wave, and then the one in red and orange on the right hand side is called our third wave. And just in the last few days, there's been some indications that our fourth wave might be starting. But really, so far, there have just been these two relatively larger community epidemics. One of the interesting phenomena that we studied and just published very recently in Nature Medicine is superspreading. Superspreading is a phenomenon where a minority of cases are responsible for spreading infection the most in the community, whereas other infected persons don't seem to spread very much. Superspreading has been reported for many different infectious diseases. It was one of the characteristics of SARS in 2003. And we showed in this particular study that in Hong Kong, COVID-19 also has a superspreading phenomenon. So in this slide, we show some of the clusters that we know about in Hong Kong. On the left is a bar cluster. In the middle panels, panel B and C, are a wedding party cluster and a temple cluster. And on the right are some other clusters. And I just want to mention as well, in this figure, you'll see some of the circles indicating cases are surrounded by boxes. They're kind of boxed in. And those indicate cases that were identified in people who had been quarantined. Because in Hong Kong, when we identify cases, the Department of Health is very good at tracking down their close contacts and getting them into quarantine facilities as soon as possible, so that if those people have been infected, they've been exposed, but have they been infected? If they are infected, we want to stop the virus from spreading any further. So we get ahead of the virus. Now, in this figure, you see a lot of cases have occurred in people who were in quarantine. But at the same time, when you look at the chains of transmission, you'll see there's a lot of chains that end without quarantine. So what that tells me is that quarantine is doing something, but it's also not been essential to stop every chain of transmission. We've seen some chains of transmission dry up even without quarantine. And that's kind of interesting. And if you look really carefully in the left-hand figure, panel A, in the bottom right-hand side of that figure, there's a yellow circle with a square around it and a superscript 1. That case is very interesting. It's an escape of the virus beyond quarantine. So there was a case linked to the original cluster, past infection onwards, to a man. He went to the quarantine camp and was subsequently diagnosed with COVID. But before he got to the quarantine camp, he'd already passed on infection to his wife. So that was maybe a pre-symptomatic transmission, and it was a chain of transmission that wasn't stopped by quarantine. But that's the only one we've identified so far, just one such case. When we analyzed this data on contact tracing and clusters, on the left-hand side of this panel, we see the serial interval distribution with an average about 5 or 6 days, some negative serial intervals consistent with pre-symptomatic transmission, some long serial intervals as well. On the right-hand side is the more interesting part. We look at how many secondary infections were generated by each case. Well, we find 70% of cases didn't transmit infection to anyone else. Now, obviously, some cases could have been identified very quickly, isolated. Some cases occurred in people who were in quarantine and then wouldn't have a chance to spread to anyone else in general. But many cases were not like that and still didn't pass on infection. So it's really interesting. It looks very consistent with substantial variability in contagiousness. Some COVID cases seem to be not very contagious. Other COVID cases seem to be more contagious. And if you combine a contagious case with a setting that transmission could occur, like that person goes to a bar, a restaurant, a wedding, dinner, a religious service, etc., that's when you have the potential for a super spreading event, a contagious case, and the opportunity to spread to lots of other people. So in this study, we estimated that just 19% of the cases are responsible for 80% of transmission events. And super spreading has got some really important implications. For control measures, it means stopping the opportunity for super spreading events to occur can help a lot. So preventing mass gatherings, preventing maybe large numbers of people gathering together, closing bars, nightclubs, other places where there are crowds is going to be really important. And another way to think about it is to say if 90% of cases are responsible for 80% of transmission, that means that most of the cases are actually the result of super spreading events. So we can do contact tracing backwards, not only forwards, to find out where there might have been super spreading events. And by going backwards into clusters, we can then find lots of other cases that maybe we wouldn't otherwise have known about. because of this super spreading phenomenon. And that approach has been used in Japan to great success so far. A lot of public health measures have been used in Hong Kong. In terms of the border restrictions, just like Australia, we now have a lot of restrictions on who can come back into Hong Kong and what happens to them when they arrive. We do have hotel quarantine for some people, home quarantine for others, and those measures have been in place since March. What I want to focus on here are the community measures in Hong Kong. So at the top, throughout the whole period shown on this slide, there's been very high use of face masks in Hong Kong. Always more than 95% of people in Hong Kong report wearing face masks when they're out in public. And in many workplaces, people wear face masks all the time. There's now a rule. There wasn't initially, but there's now a rule that in public, in the city, you have to wear a face mask. Going into a restaurant, you have to wear a face mask. And I think many other places as well, mandatory masking. So face masks has been used throughout. We also have a lot of experience with testing, capacity for testing, contact tracing, quarantine. We've been able to isolate all confirmed cases, even the asymptomatic cases. So we've done a really good job on test and trace. But if you look at the two epidemics, on the left, the first wave in blue, on the right, the second wave in red and orange, those measures, masking and test and trace, were not sufficient to stop these two epidemic waves. Transmission was able to occur despite these two important measures. So we believe both measures have an important contribution to make to control, but maybe we need more than that. And so both waves have been ended by the introduction of social distancing measures in Hong Kong, including work at home policies, policies to reduce mass gatherings, closure of bars, nightclubs, karaoke and leisure facilities, and also restaurant restrictions. Those were put in place in March to end the first wave, and then they were relaxed in May and June. We had a resurgence with our second wave. The measures were brought back, and they've just recently been relaxed. So the width of these bars indicates approximately the period when they've been in place. Those measures have now been relaxed. So again, we're anticipating there's a risk of resurgence and a risk of our next epidemic wave starting maybe even as early as this week. One of the questions internationally has been about the safety for schools to reopen. In Hong Kong, schools were closed between February and May, but reopened for a month or so in June and July when we didn't have many COVID cases in the community. And a lot of special measures, infection control measures, were put in place to stop transmission in schools, to reduce the risk for children and teachers and school staff. So that includes daily temperature checks, universal masking on school campus. That means everybody at school wears a mask all the time. Because you have to wear the mask all the time, you can't have lunch at school. So the schools switched from full day to half day. Arrival and dismissal times were staggered, and the desks were spread out. So the children sit in rows individually rather than sitting together at group tables. Various other things. And in this particular study, we identified 15 cases in children in Hong Kong in June and July, where we think there could have been opportunities for transmission, and there was no evidence of transmission in schools. So we think the measures that were put in place were reasonable measures to mitigate or to reduce the risk of transmission in schools. And the same measures are in place now. Schools have just gone back in the past week in Hong Kong. One of the other interesting things that's happened in Hong Kong last month is a universal testing scheme. So in this program, some experts from mainland China came down to Hong Kong to help to set up a laboratory that could test an enormous number of samples in a very short space of time, and also to provide expertise on how to collect such a lot of samples in a short space of time. And the universal testing scheme was open to everybody in Hong Kong, all 7+ million people, except for people that reside in elderly homes. Those were excluded. But everyone else in Hong Kong was able to participate in this scheme. And the uptake was about 20%. So about 1.7 million people were tested. And it identified among those people 32 cases that might not otherwise have been identified. A few of them were symptomatic and decided to go for the mass testing rather than going through the usual channel of going to see a doctor, because the mass testing was free, whereas going to get tested through a clinic, a medical clinic, would have been associated with a cost. But majority of those 32 cases are cases that would not have been found without the mass testing scheme. Some of them were likely in people who'd already recovered. And so although they're marked in this figure in early September, they could have easily been cases of infection in August. And the mass testing was really useful because it told us that we were missing some silent infections in the community, but not a lot. Even if we scale up to all 7.5 million people, we know that we hadn't been missing an enormous number of silent cases in the community, maybe just some silent cases. So we know we're doing a lot of testing. We know that test and trace finds a lot of cases, and probably the case numbers do underestimate how many infections have been occurring, but not by an order of magnitude. So I'll wrap up. I've explained how face masks and test and trace, we do think they're important, but neither of those measures were sufficient in combination to stop COVID-19 spread. We needed social distancing measures as well. We've identified that transmission in mass gatherings, including bars and in restaurants where there's lots of people crowded together, is really important. Identified the super spreading phenomenon in our first wave in March. And also we're looking at data now for the second wave where there's also clear evidence of super spreading. When we brought in social distancing measures, they were sufficient. And I think we're going to need those measures again to control the wave that could be starting now. We may need to bring those measures back in place later this month. And probably we're going to have periods of time when the measures are in place and then periods when they're relaxed over the next 6 to 12 months. And we also recognize that preventing imported infections is really important between waves. When we have a lot of cases in the community, stopping importation is not so critical. But in May and June, really the second wave in Hong Kong that started in June was triggered by importation of infections, possibly in people who were not required to do the home quarantine. And that's an important loophole that we really need to close if we ever get back down to 0 cases domestically. And the last thing to mention is about vaccination. So according to reports in the local media, we're aiming to get vaccines for everybody, either through the COVAX program or through individual manufacturers or both. We're hoping that vaccines might be available by next summer, at least for some of the population. And the prioritization plan most likely would be healthcare workers and elderly first. But we'll see. And one of the questions I'm thinking about right now is if we could get 1 million doses a month, starting next spring or summer, at what point would we decide we vaccinated enough people to kind of start getting back to normal? I don't think we're going to wait until we vaccinated everybody to reopen the borders, to lift the social distancing measures and so on. I think once elderly are vaccinated, once healthcare workers are vaccinated, then the risk of a very substantial health impact of a COVID epidemic would have mostly passed. And so then at that point, I think that may be the time to start thinking about what to do. So I will finish there. I'm ready for the Q&A.
Excellent. Thank you very much, Ben. Pretty interesting similarities between the two places, and somewhat depressing to me to hear that you might be seeing another wave and you've got all those other things in place. We're very much relying on the ability to test, trace, isolate really efficiently. And I think there's, we have got some questions in, so I shouldn't hog the microphone, but I do want to just ask why it seems that some places can achieve elimination through aggressive suppression, and while others you just can't get rid of it. And what I'm hearing about with Hong Kong, so China seems to have eliminated it. We have lots of states across Australia, pretty much everywhere except Victoria, maybe New South Wales, have actually just never got hold in the community. Do you have any theories on that, Ben? I would have put Hong Kong in that class because it could have, it's doing all the testing, tracing, isolating, etc. Have any theories about that?
We successfully eliminate transmission after the first big wave. By probably May, we'd eliminated local cases, and then we let it back in. So it's not clear whether it got in through quarantine or through these loopholes. We have people that come into Hong Kong on cargo ships and also air crew who are not subject to 14-day home quarantine. And there's some suspicion that at least some of the recent infections can be linked to those. So that's, basically we eliminated, but then we gave it another chance. We let it back in. And because we didn't have the social distancing measures in place, then it was able to spread. And I think maybe unlike New Zealand, where in New Zealand, there really aren't many people coming in on a daily basis. In Hong Kong, we still have quite a lot of people coming in, especially people who are not subject to the 14-day quarantine. So maybe that's where we've had a bit of bad luck, and just one of those imported infections has had a chance to spread, and that's kicked everything off. But right now, because we haven't eliminated local cases, we have not, and we've relaxed all the social distancing measures, then sooner or later, we're going to see a resurgence. I think that's very clear. That's not to say it's a bad policy, because if we kept the social distancing in place for another month with almost no cases locally, there'd be a lot of people asking why we need to do that. And, you know, maybe it would just advance this wave, get it over with, and then have a period of time when we can relax again, and it will be on, off, suppress and lift, suppress and lift. And that may be what happens in the next 6 to 12 months.
Yeah, I mean, that's exactly the position we're in right now of, you know, an average of 10 cases, you know, 14-day average of 10, wanting to get to 5, might not get there, and people getting very sick and tired of the lockdown. So Jodie might have a view of what do we do?
Well, look, I think the Hong Kong experience is really important for us here. You know, it is possible to have a redundancy of measures, I believe. And just because we have applied stricter measures doesn't mean that all of those measures are necessary to have achieved what we have. You know, I think the big, I think a lesson was there were in Victoria, in our initial response, we tried to have isolated sort of postcode, very localised interventions. It's hard to do that because people were still allowed to go to work, so mobility across the state was still relatively unaffected. And if the measures became more uniform, then I think we expected to see more effect. But I do agree with Ben that this focus on super spreading really should be where we focus our attention, because if we stop the super spreading events from occurring, then it's less, the virus is less able to get out of control so quickly. And I think if that is our policy focus, then we can look at less economically damaging interventions that would still, you know, move us towards the desired outcome. And at the moment, the groups in which transmission is occurring and grumbling along are groups that aren't really being affected by the current policy settings. You know, it's settings like aged care or some complex cases in the community, in largely marginalised communities, where those measures just don't have reach. So I think we need to question their relevance.
Yeah, I didn't actually quite understand what you meant, Ben, when you were talking about how you trace super spreaders and what Japan are doing. Could you just explain that again?
Yeah, Japan have had this idea since the early days of trying to find out where super spreading events have occurred. So when they identify cases, they already imagine that the case has come from a super spreading event. So they try and figure out where that super spreading event was, maybe by looking at where other cases have been and linking up the connections. And then when they've done that, maybe it was people at a bar or people at a religious service or something, then they go to that place and track down everyone else. And so although those people may have already been sick, maybe even already passed on infection to another generation of cases, they can get on top of it because of that. If they didn't make that effort to go back to find the super spreading event, then they wouldn't know that there are all these other cases about in the community that are spreading it onwards. Right. So contact tracing, the usual concept is you go forwards. You look for who's next in line to have been infected, and you want to get ahead of the virus. But this idea in Japan is you also go backwards before you go forwards. So you go back to the clusters, find the clusters that you didn't otherwise know about, and then go forwards from them to get ahead of the virus where you didn't even know, you know, in cases that you hadn't even realized until you started looking for them. I think it's really smart.
So they're using serology for that?
No, they're just doing
just swabs.
Do leather epidemiology. Yeah, just going back to find the people and then swabbing. Yeah. Right.
Assuming they're still PCR positive. If it's
or symptomatic as well. You can ask about symptom history. It's all done relatively quickly.
So you're going to do that in Hong Kong?
Yeah, we're doing that in Hong Kong to some extent. We are contact tracing backwards and looking for clusters. But I think Japan are the masters of that, my understanding.
All right, so we have a few, I could ask a million questions, but I can't hold the microphone as the chair. So, and we have a very important guest in the audience, Kshitij Kapoor, our Dean, who I should say is a psychiatrist, but has become a bit obsessed with COVID. So I'm going to say I'm going to appoint him as an honorary infectious disease physician and epidemiologist because his knowledge is incredible. All right, and he's asking the question, when in low transmission settings, like Melbourne, Sydney, Hong Kong, mystery cases arise, and they could be a function of A, missed contact tracing, which could have been picked up by better tracing. B, they could be a function of asymptomatic chains, which are unlikely to be picked up by better tracing, or C, they could be a function of fomite transmission. Can one really distinguish between these different streams? And what are your best estimates of the contribution of these streams to mystery cases? Ben, do you want to?
No, I don't know. So I don't. My gut feeling is that fomite transmission, environmental contamination transmission that way, is not playing a major role in COVID. My gut feeling, but I haven't seen evidence for that. It's just a feeling, just a sense. But whether these are a result of asymptomatic cases or mildly symptomatic or failures of contact tracing, I don't know. Certainly contact tracing is not perfect. There's a lot of situations in Hong Kong where we are unable to find all the people that were at the bar, at the restaurant or whatever in order to track them down. And maybe it's only later, after another generation or two of cases, that everything gets linked up, if that's going to happen. I know in mainland China, they're much better at contact tracing because of technology. So, in mainland China, there's big databases of everybody's faces and there's CCTV cameras everywhere with facial recognition. So they can find out who was on the bus that day, who was in the restaurant that day, if they really want to. They have all sorts of sources of information in order to do that. So you asked earlier how China's been so successful. I think that's one of the factors. And the other is because they're so determined to maintain elimination that they're willing to put an enormous amount of resources into locking down Beijing or other cities in China when there are these small outbreaks, and then really wiping out the virus before it has a chance to take off. So I can imagine there could still be some small outbreaks in different parts of China, but it's never going to have a chance to take off into another large epidemic like in Wuhan, because there's so much resources being devoted to stopping that from happening now.
Yeah, it's not just resources, it's also capacity, capabilities that we may feel uncomfortable introducing. Although one strategy that most likely will happen with restaurants and bars opening is that everyone will have to register. Do you do that in Hong Kong?
Yeah, we sign in. Most restaurants will ask you to sign in now.
Most, but not all. Is that? It's not.
Not all.
Yeah. Jodie, do you have anything to add to Shatija's question?
Yeah, so look, I agree with Ben's assessment. I think we know that there have been documented incidents of fomite transmission, like there have been documented incidents of airborne transmission. It doesn't mean that they're predominant outside particular settings. I think on that asymptomatic chains of transmission, I think one of the things I have taken away from the genomic data, when the first wave ended, people were worried that there were these silent spreading infections still mulling around in the community and that somehow they would pop their heads up again. What we saw in many, many settings where genomic studies were done were that, clades went extinct. So it wasn't that they were sort of still seeding and grumbling around, and it was reimportation that seeded infection. It was kind of last strain in wins. So I think, yes, there may be the odd asymptomatic or pre-symptomatic transmission event that's hard to capture, but this idea that it's somehow festering beneath the surface, I don't think that's how this virus works. It's popping up quickly or it's basically dying out. And to me, that was a bit of a game changer in how we started to think about strategies and surveillance and other things.
So you either have a super spreading event or you don't.
Well, that's right. But yeah, it's unlikely that you would have sustained chains of transmission, given that most people don't spread or they spread a lot. That kind of, if you're averaging at 1 point something and that's pretty steady, it's fine. But it's this all or nothing phenomenon means that it's less likely to be invisible for a long period of time. So the longer you go without it, the more likely it is that what you had has gone and then something might come.
All right, we have a question from Hoylan Chan, and it's around the mass testing program. What's the reason? And actually, I'm not sure you told us what was the testing technologies that was used, Ben, in the big testing. Was it saliva and regular PCR, or was it something?
Most of the COVID cases in Hong Kong have been diagnosed by saliva ever since the beginning, but the mass testing scheme was using nasal swabs and throat swabs together and PCR. And the lab, as far as we know, reported in the media, the lab pulled together 3 samples for 1 PCR test. So it was 1.7 million people tested, but probably more like 800,000 PCR tests done. And then if it was positive, of course, they retest the originals. And so, yeah, does that answer the question?
Yeah. So, well, the question was, what's the reason for choice? Why did Hong Kong choose saliva as their testing choice, as opposed to Australia nasal swab testing?
Yeah. So it's a very good question. We know that in general, the nasal swab, throat swab will have a better yield of virus from an infected person. In Hong Kong, we're not just asking the patient to spit into a tube in front of the doctor. We have what's called a deep throat saliva. So an early morning deep throat saliva. So when you wake up in the morning, sometimes you've got a bit of saliva there. That's what they want. Wow. So when they're thinking about diagnosing a case, they'll give them a tube to take home. The following morning, wake up, spit in the tube, bring it back, test it. And it seems to work about as well as a nose swab and a throat swab in terms of sensitivity. But obviously that introduces a 1-day delay into the whole process of identifying cases because you've got to wait till the next day. And I think one of the motivations in Hong Kong for using that, I don't know for sure, but I heard one of the motivations is because the healthcare workers are not very enthusiastic about swabbing patients that might have COVID. And so this was a compromise. So the healthcare worker doesn't need to do that. They can just give the tube and get the patient out back home. I mean, obviously, if the patient's really sick, then they need to be admitted to hospital. That's a different matter. But for the ambulatory cases, the mild cases, and the ones in quarantine camps or wherever else, it's done by this deep throat early morning saliva.
So there is emerging data that regular saliva might be just as good anyway.
I think regular saliva is not as good. That's the thing. In Canada, there's a study that if you just spit into the tube in front of the doctor, it's not quite as good. It loses some sensitivity. But the early morning one is not. It is okay. It's about as good as a nose and throat swab. But a regular saliva sample may not be quite as good.
Yeah, we've done some work on this here. Deb Williamson published a paper in Journal Clinical Microbe, and she found the saliva that was 87% sensitive compared to swabs. But then there's this study from Yale in the New England Journal saying that saliva was more sensitive. So we're doing actually a lot of evaluation of saliva for mass testing programs. The second question from Hoi Lam is, since both countries had second and third waves, which reduced over time, can you comment on the mandatory use of masks in Hong Kong versus non-mandatory requirements, although encouraged in Australia? Yeah. Which is not quite right, because in Melbourne, it has been mandatory. There's a fine if you don't wear a mask. So our uptake has been high in the second wave.
Hong Kong's kind of interesting because a year ago, we had a law put in place for a short space of time where masks were banned. So it was actually illegal to wear a mask. And now we have a situation where it's illegal not to wear a mask in the space of 12 months.
Yes.
But as I said, we've been measuring mask use in Hong Kong all along. And in the past 9 months, there's never been a day when in our surveys, less than 95% of people report wearing a mask in public anyway. So making it mandatory, I don't think made much difference because people were all doing it anyway. I think masks are useful, but at the same time, we've seen 2 epidemic waves in Hong Kong, despite the widespread use of face masks. And one of the factors is we've seen a lot of transmission in places where people can't wear masks, when they're eating in restaurants, drinking in bars, and obviously in households where you don't wear a mask anymore. So masks, I think they're important. I think they do help. But my guess would be reducing transmission, maybe the reproductive number by 10% or 20%, which is not enough to stop transmission when the basic reproductive number is in the range 2 to 3, and in Hong Kong, maybe even above 3. So it does some good, but we need other measures as well.
What about your view, Jodie, about mandatory or non-mandatory, universal masks or non-universal masks?
Yeah, so look, I think in particular settings and particularly in places where distancing can't be achieved, it makes a lot of sense. I think in outdoor settings, in open air environments, I think the evidence is probably thinner. Our Premier's insistence that a sole fisherman must wear one in the middle of a river alone because it's just so logical. I probably don't quite hold with that. But yes, it's hard to know the specific contribution. And I think much of what we perceive as the impact of masks in Victoria is the psychological factor for a community that's never been a mask wearing community. Having to put one on before you leave the house is a real psychological prompt. And reportedly, it's also increased the sense of community solidarity in dealing with this virus, that you go out there and everybody else is wearing one too. So I think it's probably had multi-layered impacts, but agree the evidence is not strong that cloth masks do a great deal, which is what most people are wearing.
There's a question here about privacy. In New South Wales, there's a lot of privacy protection for cases. Sex, age, occupation are not disclosed in the media, but all of these are reported in Hong Kong. And looking actually at your dashboard, you can even sort of almost find the person's address. Is this good or bad for community engagement? Ben?
I think there's been a lot of interest in Hong Kong about local levels of risk. So if there's a case in my apartment block, there'll be a notice in the lift lobby saying there's a case in the apartment block. It wouldn't necessarily say which flat, which floor, but it will say there's a case. So, I mean, that information's then in the public domain already. And in terms of the case data, there has been a history of publishing basic information, age and sex and so on of cases. It's not enough to de-anonymize them. But I mean, I agree there are privacy concerns, and probably one of the things we can look back at is the best resolution of information that's valuable for individuals in the community, for groups in the community to judge risk, and then also weighing against the rights to privacy.
There's a question here from Joy Doherty, and Joy's asked, it's about schools. With the reopening of schools in Hong Kong and resumption of activities, what are we to expect, especially if you're looking at a fourth wave? What will you do with schools?
It's a good question. In Hong Kong, people really live on top of each other. So I know in other countries, the discussions about allowing schools to continue so that parents can go to work. In Hong Kong, it's not exactly the same equation, because often families will have domestic helpers from Southeast Asia, or will have grandparents around to help with the children. And that means if there was to be a COVID outbreak in a school, it could spread to grandparents more easily than perhaps in Australia or Europe. So I suspect schools may go back to online learning if we do have another epidemic wave. It may not be the most important control measure, but I think there'll be enthusiasm from the community to have that as one of the measures, along with working from home and closing the bars and the other social distancing measures, particularly with the grandparents in mind, I guess.
Yeah, there's another question from Abigail Rath about, do you think schools can remain safely open during any future waves? Jodie, what's your view with opening up schools now? Numbers are down. If we get a resurgence, would you close them again?
Well, this has been a hot topic, but I think
you want an independent view, not the fact that you've got 2 school-age children at home. I'm very happy that they're back at school.
Not yet, almost.
Oh.
Look, at an emerging body of international evidence, as Ben said, 15 opportunities for incursion or identified incursions in Hong Kong without transmission. You know, very similar experience in Australia. We hear 1 or 2 outbreaks hailed as evidence that school transmission occurs. We had one associated with a very large Islamic college called Al-Taqwa in Victoria. But in fact, looking at that outbreak, it was still at a time of low social restrictions. This was a very widely connected community for faith-based and other cultural reasons outside the school. And it really wasn't clear how much transmission occurred in the school environment and how much occurred outside. So, you know, I think of all the things that you could do to normalise society, and of all the things we deem essential, education is essential. Certainly primary school children to me are a no-brainer. They're a group that clearly have a reduced ability to probably acquire and certainly spread this infection. In the secondary school years, it's a little bit harder, but it's also a group that can potentially be motivated to do more about their behaviours. And that's really more of a judgment call, you know, around the middle years. But of all the things we can do to normalise society and improve, as Ben pointed out, you know, working adults' ability to work, that's a substantive move for our society.
And this is final. We've got a few questions here. Well, actually, 2 of them are linked. One's from Miranda Smith. It's for Ben Cowling. She's asking you, Ben, because she works for Jodie, so she knows what Jodie's going to think. Is there any emerging evidence for what creates a super spreader? Is anything known about whether it's viral or host that determine whether an infected person would be in the 20% that become super spreaders?
No, it's a really good question. And I think probably it's more than 20% of people that could be super spreaders. It's 20% that have super spreading events. So maybe there's just a distribution of contagiousness. We don't exactly understand why. And if you have a contagious person who goes to a bar or goes to a large gathering, that's when you get a super spreading event. But some of those contagious cases might be the kind of people that just stay at home a lot, or, you know, maybe their symptoms are such that they already self-isolate and don't create a super spreading event. So we're looking to see if we can figure out the characteristics, but no good answer yet.
Okay, well, we're on the hour now, so I will need to finish up. Thank you both, Jodie and Ben, for two fabulous talks. So much similar between the two countries and so much to learn from each other. This is the first of 4 seminars that we'll have. We'll have very different focus in future seminars. I hope people that are attending from the University of Hong Kong and the Doherty and or Fudan, Tsinghua, as well, are thinking hard about who you might want to work with in each of those institutions, because part of this is to, you know, establish some collaborative programs as well as education from the seminar series. And we also had planned to have some visits actually, but I don't know whether that's looking too promising in the next 12 months, unless we create a bubble with Hong Kong. Fingers crossed. It's not looking so good, but fingers crossed. So thank you everyone again, and special thanks to Mason and to Encore for the Zoom format, and we'll see you soon at our next seminar in a couple of months. Thanks everyone. Bye.